Listen-only mode.
Hello, good afternoon. Thank you for joining today's presentation hosted by the Sudden Arrhythmic Death Syndrome Foundation and Invitae, entitled Latest Diagnostic and Treatment Strategies for Arrhythmogenic Right Ventricular Dysplasia or Cardiomyopathy. Before we begin, I would like to let you know that the attendees, will have the opportunity to submit questions to our presenters today by typing them into the questions pane of the control panel and clicking send or submit. You may send your questions in at any time during the presentation. We'll collect them and address them during the question and answer session at the end of today's presentation. I want to let you know that today's webinar will be recorded and will be available for later viewing. With that, I would like to now introduce you to today's presenters, Dr. Hugh Calkins, who is Professor of Cardiology and Director of the Electrophysiology Laboratory and Arrhythmia Service at the Johns Hopkins Hospital, and Brittney Murray, who is the Clinical Genetic Counselor and Program Coordinator of the Johns Hopkins Hospital ARVDC program. Dr. Calkins and Ms. Murray, we thank you for your participation and have been looking forward to it, and I now turn it over to you.
Great. Good afternoon, good evening. I'd like to thank the SADS Foundation for putting on this webinar on what we believe is a very important topic, which is arrhythmogenic right ventricular dysplasia or cardiomyopathy. So what we'd like to do over the next, I think, 40 minutes or so is to provide you with an overview on ARVD. Then Brittney will update you on the genetic basis of the disease. I'll then discuss the clinical presentation and follow up with these patients. We'll go over management and wrap things up. So ARVD is a genetically determined cardiomyopathy which is characterized by progressive replacement of right ventricular myocardium by fatty and fibrotic tissue, and clinically by ventricular arrhythmias that arise predominantly in the right ventricle. It's also now well recognized that there's a left dominant form of the disease, and so some have proposed renaming the disease arrhythmogenic cardiomyopathy, but we prefer the term ARVD, reflecting the fact that, in the U.S. version of this disease, right dominant disease is by far the most common manifestation of ARVD. Now, this is a rare condition. It's about 1 per 5,000 in the United States, a little bit more common in Italy. It's equally common in men and women, although men have a somewhat more active course or at higher risk. ARVD counts for about 20% of sudden deaths of young people in Italy and about 5% in the United States. Now, to put this in context, as we all know, hypertrophic cardiomyopathy occurs in about 1 in 500 individuals. So one could argue that this disease is 1/10 as important as hypertrophic cardiomyopathy, but that's obviously not the correct interpretation, because if you actually look at the data, this is a recent study from the UK where they looked at sudden cardiac death in sports, and if you look at the deaths caused by ARVD, shown in orange, 13% of these deaths, compared to hypertrophic cardiomyopathy in green, you can see twice as many of these sudden deaths were caused by ARVD. So although it's a far less common disease, it's a far more lethal disease than hypertrophic cardiomyopathy, and I congratulate everyone for taking the time out to spend time on this call tonight. Now, when you look at the history of the disease has been known to exist for hundreds of years, but it wasn't until 1982 when Frank Marcus went on a sabbatical in Paris with Guy Fontaine and put together this series of patients that ARVD really came to the forefront of, really received medical attention. So back in 1982, 24 cases were described. These were pretty severe disease, and this was sort of a landmark publication that really launched the modern form of this disease. And here they used the term, right ventricular dysplasia. Now, this was a very important paper, but there was one figure in this paper which was a little bit off, and that's this figure showing what's referred to as the triangle of dysplasia, the outflow tract to the right ventricle, the inflow tract to the right ventricle under the tricuspid valve, and the RV apex. And they were trying to highlight the fact that ARVD affected these three areas of the right ventricle. So they were correct that there is a triangle of RV dysplasia, but it never involves the apex in early disease. So this leg of the triangle is in fact in the wrong place. And our research has shown that the true leg of the third leg of this triangle is the posterolateral LV. So ARVD affects the inflow tract of the right ventricle, the outflow tract, and the posterolateral LV. And the apex is only involved in very severe disease when the entire right ventricle is affected. So it's important to notice that when someone's trying to read an MRI or whatever, and the apex doesn't seem to be moved normally, that's not where ARVD impacts the right ventricle. Now, when it comes to diagnosing ARVD, we now rely on the 2010 diagnostic criteria. Again, one of many, Frank Marcus's many contributions. And I think this was a sort of a redo of the initial task force criteria that had been written by the task force led by Bill McKenna. Now, if you compare the 1994 criteria with the 2010 criteria, you can notice some important changes. First, on the left side of the screen are all the different parameters you have to think about when you're evaluating someone for ARVD. What's their RV size and function? And did they get a biopsy? What did it show? Do they have T-wave inversions, V2 and V3? Do they have an epsilon wave? And so forth. And here's the 1994 criteria. Here's the 2010 criteria. And suffice it to say that the 2010 criteria are more specific, and they also put more emphasis on T-wave inversion in the right precordial leads. So a major criteria is T-wave inversions in V1 through V3, whereas previously this was not a major criteria, and so forth. And they also anyhow. So I think it's important to be aware of this paper. If you're trying to diagnose this disease, pull out these tables and try to apply them as best as you can. In general, a major criteria gets you 2 points, a minor criteria gets you 1 point, and to get the diagnosis you need 4 points, 1 major, or 2 minor, or 4 minor, and so forth. Now here's an EKG of one of our patients with ARVD, and when you look at this EKG, you can instantly recognize that it's abnormal with this T-wave inversions and leads V1 to V3. And again, this is a major criteria for ARVD. But when you look closer at this EKG, you can also note that the S wave seemed to have a stutter step. Getting from the S wave back to the baseline takes quicker than usual. And this is a parameter we call terminal activation delay. If this is more than 55 milliseconds, that gets you 1 minor criteria for ARVD. It's a little bit like the signal average EKG without a signal average machine, but that's important to note. Now, shown in this slide are a series of EKGs of patients with ARVD showing leads V1, V2, and V3 from 4 different patients. And as you look at these EKGs, I want to have you ask yourself, is there an epsilon wave? And I think one of the interesting things about the diagnostic criteria is one would think it would be very easy to identify is there an epsilon wave present. But as it turns out, it's very hard, and there's very poor inter-reader variability, even among experts. So recently a study was done looking at this, where they took EKGs from many patients with ARVD, they sent them out to experts or self-proclaimed experts in ARVD and said, is there an epsilon wave? And it was all over the map. So if you look at this EKG, one could argue, well, that's a very clear epsilon wave, major criteria. But if your criteria for epsilon wave is you look at simultaneous V1, V2, V3, you'd say, well, the QRS ends here, which means that epsilon wave is really not outside the QRS complex. It's within the QRS complex, so it's not a real epsilon wave, and neither is that. So you'd say there's no epsilon wave here, but many people would disagree. So anyhow, this is the group that was assembled to read all these EKGs: Guy Fontaine, Frank Marcus, Domenico Corrado, Richard Hauer, and Peter Platnoff led this effort, Wojciech Zaryba, and we ended up putting together a paper basically saying that the inter-reader variability in epsilon waves is so great, it's really not a helpful parameter. And when we went to our databases, we found that it didn't make any difference in diagnosis, that if someone has an epsilon wave, they have severe disease and they meet all the criteria without including the epsilon wave. So we basically have encouraged those evaluating patients not to include the epsilon wave as one of the points in the diagnostic criteria. because if it's early ARVD and you misinterpret the epsilon wave, you'll all of a sudden be halfway to the diagnosis, and that really would be a mistake in our experience. A few words on MRI. MRI is a great way to look at RV size and function and LV size and function. You can also look at gadolinium enhancement. You can see, aneurysm formation. So it's a very good, diagnostic test, but it's also the most common reason for overdiagnosis or misdiagnosis of ARVD. And this is due to the fact that there's a lack of awareness of the diagnostic criteria for ARVD. Many people incorrectly believe that the MRI is the gold standard, and if you have evidence of ARVD in an MRI, that's all you need to make the diagnosis, and that's obviously a big mistake. Others fail to recognize that myocardial fat or wall thinning on an MRI are not even included in the diagnostic criteria, and yet many misinterpret fat on an MRI as meaning ARVD. That's a mistake. Also, fail recognition that RV wall motion abnormalities may result from an RV free wall tether between the RV and the sternum, a pectus, or a moderator band. And then there's the problem of overdiagnosis of apical aneurysm, and as I noted before, that ARVD spares the apex unless you have severe RV involvement. So now I'm going to turn it over to Brittney, who's our lead genetic counselor at Hopkins and our Cardiology and Inherited Heart Disease Clinic and the ARVD program, and she'll take you through the genetics.
Okay, so starting around year 2004, 2002, that there were some of the first papers came out really describing that ARVD is actually a disease of the cardiac desmosome. And from there, after desmoplakin was identified and plakoglobin as one of the most crucial parts of the desmosome and being involved in ARVD, other desmosomal mutations were quickly identified as also contributing to ARVD, including these studies, this study about desmogliin and desmocolin, the other parts of the desmosomal complex that we see today. So, arrhythmogenic right ventricular cardiomyopathy is a disease of the cardiac desmosome. We most classically think about the desmosome as 5 genes really holding together the glue between the cells, or as I often say in clinic, the bolts between the heart cells holding the heart cells together. This is, again, showing an electron micrograph, really showing that in this intercellular mechanical junction between the cells, you have these complexes holding these connections together. And disruption of this complex and mutations in these genes can lead to disruption of this intercellular mechanical junction and all of the features of ARVC that we see. So in the current hypotheses, which are continually evolving as we understand more and more about the mechanisms of ARVC, but at a most basic sense, we understand that ARVC is caused by desmosomal gene mutations that are inherited. They're present at the time of birth. However, we don't see ARVC in young children. It's over time due to a whole host of things, including mechanical stress, exercise that Dr. Calkins will talk about later, that you see gap junction remodeling, desmosome remodeling, disruption of nuclear signaling, which leads to myocyte death, apoptosis, fibrogenesis, and adipogenesis, which then leads to what we see as the fibrofatty replacement, wall thinning, and structural changes in the RV, and the scar that can result in the ventricular arrhythmias, which are so common in our patients. So in the US, as Dr. Calkins says, plakophilin-2 is the most common genetic mutation in ARVC seen in the US, resulting in right-sided disease most commonly, although it can be biventricular and left presenting. Just a quick notes about some other genes that have been seen on genetic testing panels for ARVC in the past. Ryanodine receptor, RWR2, we most classically understand as being responsible for causing CPVT. So we actually think that RYR2 mutations are not causative of ARVC, but rather CPVT, arrhythmias in a patient who may have been especially athletic can have a slightly dilated RV can lead to a phenocopy of ARVC, but not true ARVC. TGF-beta has been reported, but has never been seen by our clinic. Transmembrane protein 43 is a founder mutation out of Newfoundland. It's very, very rare, but it is a very highly penetrant and lethal mutation when found. We do see some correlation with more than one mutation in one patient, so compound heterozygosity, leading to more severe disease in some cases, which I'll talk about. Right now, on small sequencing panels that have been around for the last decade or so, previously we would say we can find a mutation in an ARVC patient meeting diagnostic criteria in about half of those patients. So the sensitivity of genetic testing ARVC was always thought to be around 50%. So new data in 2016, now that we have larger arrhythmia panels, we went back and looked through our data, and we found, in our data that 40% of those sequenced on genetic testing would have had a mutation found on one of these small 5 to 7 gene sequencing panels. But importantly, with the advent of these large sequencing panels, which include deletion duplication analysis and other genes, 7% had a large deletion or duplication in the desmosomal genes, which would not have been picked up on sequencing. And 11 pathogenic mutations were found in non-desmosomal genes, 2 in phospholambin, which is a known contributor to ARVC, especially in the Netherlands, lamin, a few in the sarcomere genes, SCN5A, which has a ever-expanding phenotype, and some other arrhythmia genes. What we think is really important is that 4 of these families had not only a pathogenic desmosomal variant, but also had another pathogenic variant and another cardiomyopathy gene. So if you would have done sequencing alone of the small 5 ARVC genes, you may have thought you found the answer, but we're missing another disease gene segregating in the family. So typically here at Hopkins, we use larger genetic testing panels when we're doing genetic testing. So we looked at our patient population and we tried to determine what is the impact of genotype on clinical course in ARVC, and what do we see. So the most common type of mutation that we see, as we've said, is that most of our patients have a PKP2 mutation, seen here in orange. In the United States, this is what we most commonly see. But then we also see a lot of phospholambin, desmoglian, and some desmoplakin in our population as well. Most of the mutations that we find that are pathogenic and segregating in these families are premature truncating variants or splice site mutations. So it really would encourage a lot of caution with interpreting missense mutations in the desmosomes because they are very often don't have enough proof for pathogenicity and may not segregate with the disease in a family. Most of the pathogenic variants we see are truncating. So through this paper, we looked and said, okay, what are our main findings? So patients with mutations are younger, and those presenting younger have sudden death and more severe arrhythmias rather than older patients. We also found that patients with more than one mutation had an earlier age of onset and an earlier occurrence of sustained VT compared to those with only one mutation. We also know that one of the strongest genotype-phenotype correlations that we see in ARVC is that LV dysfunction is very strongly related to genotype and is more common in patients with desmoplakin mutations and with non-desmosomal mutations, especially phospholambin. Therefore, in patients with these genotypes, we are much more aggressive with our heart failure management and heart failure medications. We also found that gender impacts phenotype. So while this is an autosomal dominant disease and the mutation can be passed on to men and women equally, presentation with sudden death was mainly in men, and men were more likely to be proband and more symptomatic at presentation. So on one hand, you could say that men may be exercising more, but in the US, we know that women often exercise just as much as men. So there's a lot of evidence that is currently coming about the impact of testosterone in disease severity, and that it may lead to a more severe disease course in men than women. So now I'll have Dr. Calkins talk through a little bit of that clinical presentation and follow-up of our patients.
So let me start with this study, which we published a fair number of years ago, but I think the message is the same now as it was then. So this was a series of 100 patients with ARVD, 69 of which were diagnosed while living and 31 on autopsy. And what you can appreciate is the average age of presentation was around 29. About half of them were high-level athletes, and they presented with either palpitations, syncope, or sudden death, and rarely were asymptomatic or picked up during some sort of screening test. So this is from that paper in 2005 showing a Kaplan-Meier curve showing freedom from symptoms, freedom from arrhythmias, and this is freedom from this is freedom from heart failure, and this is live and mortality. Anyhow, the point of this slide is to make the point that the symptoms and the manifestations of ARVD don't show up till puberty. You can see it's not until around the age of 16 or 17 that we see our very first manifestations of ARVD. And this is really true today, that we just don't see 2-year-olds, 5-year-olds, 10-year-olds with ARVD. It's really the teenage years, 12, 13, 14, 15, 16, where it begins to show up. And this slide makes the point that the symptoms correlate with arrhythmias, and heart failure is a later manifestation of the disease. Now, this is some data we put together on patients who ended up needing to get a heart transplant because of ARVD. And each patient is shown as a line, so there's 18 different patients, and their age is shown here. And the line of the story of each patient is shown by a series of symbols. So before they get diagnosed with ARVD, it's a dotted line, and when they get diagnosed with ARVD, it becomes a solid line. And then the heart failure stage is shown as a color code from black to red to blue to green to purple. And events like VT events are shown by X's, defibrillator shocks by O's. Anyhow, the point of this slide is of the 18 patients who needed a transplant, 61% were male, as Brittney pointed out. The symptom onset, they first presented around the age of 24, about 10 years earlier than the average patient, but they didn't need a transplant until about 16 years later, around the age of 40. And the reason for transplant was heart failure in 13 and VT in 5. And increasingly with catheter ablation and other approach to control VT, I think it's becoming extremely rare to perform a transplant for VT, but rather it's really heart failure that is the reason to need that transplant now. So let me go to the, hold on one second. Oh, hold on one second. Here we go. So recently we updated our experience with 1,001 patients and family members. Now this was a joint effort with Richard Hauer's group in the Netherlands. And what we found is this shows the same kind of Kaplan-Meier curves of patients. These are index patients with pathogenic mutations and those without an identifiable mutation. And again, you can see the same relationship between age and symptoms exists, rare before sort of 16 or 17. Symptoms correlate with arrhythmias and need for heart transplantation or death or late manifestations of the disease. You'll also notice that those that had a mutation presented at a younger age than those who didn't. So the mean age of presentation was 34 mutation carriers versus 38 in those without a mutation. So now let me move on to management of this disease. And when you think about management of ARVD, we think about sort of a 4-legged stool, or maybe we should consider it now a 5-legged stool. The first leg is to get the diagnosis right. That's obviously incredibly important. Once you made the diagnosis, then you have to decide, does this individual meet the risk needed to justify a defibrillator being put in? And then once you put a defibrillator in, you then need to manage symptoms, hopefully prevent the defibrillator from going off, and you also need to prevent progression. So these are really 2 legs. And then you have the important topic of family cascade screening. So in terms of establishing an accurate diagnosis, we went over this earlier. I just want to emphasize that you have to do a comprehensive evaluation, including a history, including a family history, exercise history, physical exam, EKG, signal average EKG, Holter echo, MRI, and stress test. And then genetic testing is extremely important when the diagnosis is suspected. And then we apply the 2010 task force criteria. Now, I want to call your attention to one rather new test that has been proposed by the group in Bordeaux, which is the high-dose isoproterenol infusion test. So what they did is they took 412 patients with PVCs and possible ARVC, and they gave them 45 mics per minute of isoproterenol for 3 minutes, sort of an unbelievably high dose. And what they found is that patients with ARVD ended up having lots of arrhythmias. They had this positive response where you triggered reams of VT, frequent runs of non-sustained VT. This is sort of what they would see in ARVD patients. Now, we've been doing this test as well here at Hopkins, and I have to admit that we see the same thing, that it really does seem to light up arrhythmias in patients with ARVD. I think making us all aware that these are oftentimes due to triggered activity or automaticity rather than just reentry. But we've been using this test more as a risk stratifying tool, that if you get these kinds of arrhythmias just with isoproterenol, our early data suggests these are the higher risk patients versus ones where it stays pretty quiet, but we're just still gathering data on that. Let me just move on to risk stratification for ICD implantation. So when you think about variables for sudden cardiac death risk, you obviously think about a history of sudden death or sustained VT. Proband status. It turns out probands are at far higher risk than family members. The extent of disease is important, although we're all worried about that rare patient with very early disease who presents with a cardiac arrest and is almost, a disease so mild you can't even see it. We really don't see that. PVC frequency on a Holter is extremely helpful. Cardiac syncope, exercise plans, results of EP testing, and that isoproterenol infusion. And then importantly, patient preferences and values. Now, we wrote a paper a number of years ago looking at 84 patients that had a primary prevention ICD. None of these patients have had sustained VT before. The average age was 31. About half were men. They were followed for 5 years. And we wanted to look at predictors of appropriate therapies. So here's one figure from the paper making the point that an appropriate episode of VT occurred in nearly 60% of patients. So when we call it arrhythmogenic right ventricular dysplasia, it really is arrhythmogenic. I mean, these are a far higher rate of appropriate ICD shocks than in most studies for any other disease I'm aware of. And even when you say, well, I just want to look at stuff with a cycle length of 240 or shorter, it's still about a 25% appropriate ICD therapy rate at about 7 years of follow-up, really speaking to what high risk many of these patients are. And here are some of the predictors we looked at. The results of EP testing separated those with or without appropriate therapy. PVC frequency, more than 1,000 PVCs in a Holter. Non-sustained VT in a Holter was helpful. And look how powerful proband status was, that the family members were at much lower risk than the probands, which sort of is counterintuitive. You'd say, my goodness, if the father had a cardiac arrest from ARVD, the son's got to have one, and that's exactly not the case, that there's no predictive ability in that. So here's some more data on the relationship between PVC frequency and appropriate ICD therapy. So we broke it down into 20% ranges. So if you had less than 305 PVCs, almost no one had an appropriate therapy. More than 6,000, almost everyone had an appropriate therapy, and a remarkably linear relationship. I should say that we did another study showing that PVC frequency is pretty reproducible day to day in these patients. And here's the same thing with the Kaplan-Meier curve, that based on the PVC frequency, a very, very strong, and sort of linear predictive value. And then if you add the number of risk factors, are they a proband? Do they have how many PVCs? What's the results of EP testing? Obviously, the more risk factors you have, the higher risk. So who should get a defibrillator? Clearly, if someone has had sustained VT or VF, we'd recommend defibrillator implantation. If they're a proband and they meet task force criteria, we generally would put defibrillators in those individuals. We're much more selective about family members. They've got to have high-risk features like non-sustained VT or severe disease or cardiac syncope. And then obviously, if someone's had arrhythmic syncope, that's, I think, an important factor to consider. So let me move on now to the issue of managing symptoms and preventing progression before we get on to the family screening piece. So I've shown here results of a manuscript that we have in press in JAMA Cardiology that has not been published yet. It's been presented at a national meeting, but it's been accepted for publication. And here we took, working with the Dutch, we took 80 patients with ARVD and we did an echo about 5 years apart on average. And we looked at what happened to RV function and LV function, RV size, and what we found, as you, I guess, would predict, is that over time LV function decreased. I mean, RV function decreased quite significantly. LV function decreased. RV volumes and RV volumes went up. So for those of you or those who aren't on the call who think ARVD is not a progressive disease, I'd like to call your attention to what I think is a very important paper. I think it's consistent with what we have seen, but up until this point, there's been only a small series. There's been nothing of this size or magnitude, making it very clear this is a progressive disease, and we have to take preventing progression seriously in order to prevent heart failure and need for transplantation and other things. So how can we stop progression? I think the most important by far is to stop exercising. I used to say think pack years of exercise, but it's not so much pack years of smoking, it's sort of chain smoking, and we'll go over that. Take beta blockers. I think beta blockers reduce arrhythmic risk, and I think based on heart failure studies, they probably help prevent progression. And same with ACE inhibitors, that we have a low threshold to use ACE inhibitors, particularly if there's evidence of a reduced either LV or RVEF. So, and then in terms of minimizing symptoms and defibrillator shocks, again, stop exercising, take beta blockers. We think the ACE inhibitors may be helpful. And then in select patients, we'll use antiarrhythmic drugs. And I think our first drug we typically will use is sotalol, less commonly flecainide or Ticacin, and fairly rarely amiodarone. But if someone doesn't want a catheter ablation procedure and they failed sotalol, that's not a bad option. And then obviously catheter ablation plays an important role. So let's go over the exercise story a little bit. So what data exists to support this recommendation to stop exercising? These are in patients who love to exercise. So we know that ARVD is a disease of the desmosome. We know desmosomes sort of glue cells together, and during exercise, RV pressures triple, and the RV dilates, so the wall stress goes up dramatically. We know that most ARVD patients, particularly those that present at young ages, are high-level athletes, usually starting vigorous exercise at 6, 7, or 8. Exercise is a common trigger of arrhythmias and sudden death in these patients. And now there's probably been 4 or 5 mouse studies showing the provocative role of exercise in mouse models of ARVD. And there's been a number, I think actually 4 clinical studies to date, 2 from Hopkins, 3 from Hopkins, 1 from Sweden, and 1 from the US ARVD study in patients showing the importance of this relationship. So let me just go over some of this data. This is our first paper on this that Cindy James put together. We looked at 87 patients that had a desmosomal mutation, and we took lifetime exercise history in all these individuals and also classified them as to whether they're an endurance athlete or not. And what we found is that the number of hours per year of exercise prior to presentation correlated closely with whether in fact they met the task force criteria for ARVD. So in those individuals, again, each of whom had a desmosomal mutation, of those who exercised the most, 510 to 2,600 hours of exercise per year, 85% met diagnostic criteria, where only 28% of those that exercised less than 134 hours per year had evidence of ARVD. And similarly, if you just broke it down into endurance athlete, yes or no, you showed the same relationship. Here's the data showing just breaking it down into are they a competitive athlete or endurance athlete or not. Those that are an athlete had a much higher rate of VT and VF than those that were not an athlete. And similarly, when we look at heart failure, no heart failure in non-athletes and a lot of heart failure in athletes. So again, I think fairly compelling data. Now, recently, we did some work looking at what the relationship is between exercise and patients with ARVD without a desmosomal mutation or identifiable desmosomal mutation. And what we found was quite striking, that if in individuals with a mutation, so they have a desmosomal mutation, no family history, we'll say, but or a desmosome with a family history, it took on average 3,100 MET hours of exercise prior to presentation to develop the disease or meet task force criteria. If you look at gene-elusive patients with ARVD without a family history, it took 6,700 MET hours of exercise, so almost twice. Sort of the double hit hypothesis that if you have a desmosomal mutation, it takes a lot less exercise to get ARVD than if you don't have an identifiable mutation. So this just shows the schematic of this. The genetic influences in blue, exercise influences on white. If you have a mutation, you have a lot of genetic predisposition, doesn't take much exercise, whereas if you don't have a mutation, it takes a lot more exercise to bring out an ARVD phenotype. We also did some work trying to figure out what's a safe exercise level, and to do this we interviewed families that had PKP2 mutation, but I think a couple families will teach you a lot. So here's two families, each of whom there's a PKP mutation in each of these individuals. And their amount of exercise is shown in the vertical axis. This is cumulative MET hours per year, so hours of exercise times intensity. And this is their age. So in this family, this is the proband. At the age of 10, this guy's exercising like a fiend. And by the age of whatever, 25, he's done 50,000 MET hours of exercise. Gets ARVD, that's what the arrow means, has VT, and then he cuts down his exercise. Here's three siblings, all of whom exercise dramatically less, and none of whom developed VT, and only one of whom developed evidence of ARVD much later. And these are the AHA recommendations. I think they recommend 20 to 30 minutes of moderate exercise 3 or 4 times a week. So if you exercise less than what the AHA recommends to stay healthy, you seem to do fine. If you do it more, you have problems. Here's another family showing the same thing. Look at this individual started exercise at the age of 10, 90,000 MET hours of exercise, or 70,000 by the age of 15 when he got diagnosed with ARVD, had VT. Again, here's the siblings doing fine under this AHA cutoff. And this is just sort of cumulative data showing the same thing that I won't dwell on. A few comments about catheter ablation. Certainly I think that EP testing and a limited endocardial ablation procedure is appropriate at a time of initial evaluation or diagnosis. In a lot of these individuals, one of the differential diagnoses is idiopathic RVOT-VT, and certainly if you get in there, it behaves like RVOT-VT, it responds to ablation like RVOT-VT, and everything looks fine. There's no need to be looking for weird things like ARVD. But if you induce 3 different morphologies of VT or have a positive isoproterenol infusion response, you got to think a little more broadly. Catheter ablation, endo. Really, we do sort of combined endo-epis recommended for patients receiving frequent ICD therapies despite drugs, or if a patient doesn't want to take antiarrhythmic drugs, it's certainly reasonable to do a VT ablation in an experienced center. So here's some of the data from our registry. Here's 87 patients that got 175 VT ablation procedures, 2.3 per patient. 26 of these were epicardial. There were 2 major complications, and these were followed for about 6 years. And you can see somewhat disappointing results. This is the epicardial ablation, endocardial ablation, and I think this was somewhat sobering. Again, this is in the registry with many centers performing the procedure. More recently, my colleague Harry Tandry, who leads this effort at Hopkins, published his data on 30 patients with ARVD performed at Johns Hopkins. Endo-epi procedures. Most had failed drugs or a prior ablation procedure. They were followed for about 2 years, and we now have about a 70% success rate. I think more importantly is that there have been no complications. Right now, I think we are up to over 100 VT ablations, endo-epi VT ablations, and again, touch wood, no complications and similar efficacy. So we're pleased by those results, and certainly we believe that VT ablation plays a role. This is just sort of the frequency of PVC of VT therapies pre and post ablation. So even when it doesn't work completely, it improves quality of life. Okay, now I'm going to move on to Brittney, who will go over the important issue of family screening.
So Dr. Calkins and I often talk about that getting the diagnosis correct in the proband is really only half the story, because we know that ARVD, all ARVD is a genetic disease, and so it's really important to continue cascade screening in the family and identify others who may be at risk. So we looked at this in our registry, and we looked through what is the yield of serial evaluation in at-risk family members, and we really looked through this study trying to identify what are the most helpful tests, what are the most useful tests, how does ARVD show up in family members, and is family screening effective? These were 117 relatives followed through our registry. We followed them with ECG, Holter, signal average, and MRI testing as per the task force criteria. And then we looked for outcomes, including disease progression, new task force criteria occurring during follow-up, and occurrence of sustained VT or VF. So the results of the baseline evaluation really saw that the biggest abnormalities that we saw appearing were new electrical and new structural abnormalities. We do see that family members develop disease over time, but the thing that we saw changing first, and what we believe is the most important testing, was the electrical progression preceded the structural progression. So ECG and Holter monitoring is very important in our screening that we follow our patients with here. So among the 74 patients who did not have ARVD diagnosis at baseline, none of them experienced sustained VT or VF. But with the 43 individuals who were asymptomatic but did meet diagnostic criteria at baseline, we had a percentage who did experience sustained VT or VF in follow-up. But importantly, all of these individuals were properly diagnosed and managed and had ICDs prior to their first VT and VF. So we do feel that the screening protocol that we've developed is effective. So the summary of this paper was that ARVC relatives without a diagnosis at first evaluation have a good short-term prognosis, although certainly longer-term follow-up is needed. But a third of patients did experience disease progression during 4 years of follow-up. We find that electrical abnormalities precede detectable structural changes, and so we really focus a lot on ECG and Holter monitoring, and we space out our cardiac MRI follow-up. We really feel that cascade genetic testing is really important to identify those in the family that are at risk and target screening. If you have a genetic mutation in a family that you're confident in is that a real mutation with a lot of data behind it, as we continue to get larger and larger panels, we need to make sure that the mutations we find are actually contributing to disease. But if you have a mutation that you're confident in, you can identify and continue following relatives only that carry the risk factor in the family. Also, outcomes in these patients are really impacted by genotype. Family members most likely to family members most likely to develop the diagnosis of ARVC in this population were those that had a mutation and were symptomatic. So this is important data on who to concentrate in on the family. So the Hopkins approach to screening family members, we start initial screening around 10 to 12 years of age. I usually say, around the start of puberty, although we start as early as 8, depending on, how athletic they may be hoping to be. Screening here involves the ECG and Holter, and an MRI or electrocardiogram. If it's done here at Hopkins, we'll do an MRI, but they have a tendency to be misread, so if it's done locally, we may just do an echo. The frequency of the substitute screening really depends on mutation status and exercise plans. We really encourage asymptomatic mutation carriers to avoid exercise, because all the data that Dr. Calkins presented, they may be able to avoid getting disease altogether. But if they feel strongly that they're going to continue exercising because they don't have any evidence of disease, we're going to watch them much more carefully. But in the absence of exercise, we generally repeat screening every 2 to 3 years. However, if you're exercising, we obtain semi-annual ECG and Holters, and we generally really try to strongly encourage avoidance of exercise altogether. So Dr. Calkins and I will wrap up here so we can have some time for your questions. As Dr. Calkins said, ARVC is a rare but important cause of sudden death. It's a disease of desmosomal dysfunction. the diagnosis is challenging and requires a comprehensive evaluation. So being slow to make the diagnosis and being confident in your diagnosis is important. Identification of genetic and clinical risk factors for sudden death remains an active area of investigation and a big focus of our program in avoiding sudden death. And to that end, we recommend ICD implantations for probands who meet task force criteria. Catheter ablation continues to play an important role in management, and the data just continues to increase that vigorous exercise increases the chance of both developing ARVC and results in a greater chance of more VT and heart failure in these individuals. And we are pretty strong in our recommendation to advise against exercise. Obviously, we have a huge clinical program here at Hopkins, but we have a big registry as well. So we'd love to enroll any patients that you're following in our registry so we can continue to learn more. And then we will go ahead and pause for questions from there.
Great. Thank you, Brittney and Dr. Calkins, for that terrific presentation. I'd like to remind the audience that you're able to submit questions by entering them into the question pane and clicking submit or send. We've had some filter in, and let's go ahead and start. So what do you believe accounts for the 20% versus 5% difference in sudden deaths associated with ARVC in Italy versus the US?
I don't exactly know what that difference is. I think one of the differences in Italy, they have quite different distribution of mutations than in the United States here. And in the Netherlands, PKP2 is by far the most common, whereas in Italy they have different exercise. They also have, I say the 5% in the U.S., is a sort of an old number. If you look at that study from the UK, where I think it was, what, 12 or 16%, it's probably, so I think the US is probably somewhat less, but I think it's probably because ARVD is a little bit more common in Italy, and they have different mutations.
Thank you. In patients with ARVD, do you see PVC VT morphology with left bundle branch block morphology and superiorly directed axis more often than PVC with inferior directed axis? Would you?
I'd say, I mean, so the significance of a left bundle superior axis PVCs or VT, is much more specific for ARVD than left bundle inferior axis, which could just be triggered VT from the outflow tract. So the significance, I think, is quite different. We have a lot more emphasis. If you see left bundle superior axis PVCs, that's much more, it's much more points to the diagnosis of ARVC. In terms of how often we free see them, I think it's probably equal. About half the time they're superior axis and half the time inferior axis.
Thank you.
And I think that's consistent with the fact that both the inflow tract and the outflow tract, are two legs of that triangle, with the posterior lateral LV being the third leg.
Speaking in the voice of the audience member, did I hear correctly? You recommend ACE inhibitors for isolated RV dysfunction. Can you discuss the rationale and data, if any?
Yeah. So there's no data. The rationale, at least from my simplistic way of thinking, is that there's been countless studies showing that ACE inhibitors are helpful both for preventing progression of LV myopathy, both in terms of preventing progression and also causing regression. With ARVD, there's obviously no studies because it's such a rare disease that it's virtually impossible to do studies of that type. But I think what's good for the LV has got to be good for the RV, is my simplistic way of thinking. And it's about risk-benefit. I think the risks of an ACE or ARB is close to zero. And if the benefit, and I think there's some benefit, exactly what that benefit is, I'm not sure. But given that we know that ARVD is clearly progressive, and we don't have specific therapies to stop progression other than exercise, we have a low threshold to put ACE or ARBs in the water just because they're good things, at least from my perspective.
Great. Brittney mentioned that LV dysfunction is more common in patients with desmoplakin and non-desmosomal mutations. Do you treat these patients more aggressively, and if so, how?
We do. So our patients with desmoplakin mutations, they tend to have earlier onset of left-sided disease, more severe structural disease overall, and tend to do a little bit worse. So yes, we follow them very closely. We get more frequent imaging in these patients. Dr. Calkins just talked about ACEs and ARBs. We're much more likely to use ACEs and ARBs very aggressively and have them followed very closely by our heart failure colleagues with metabolic stress tests every year. And we watch their function very closely compared to, for example, PKP2 ARVC, which patients generally stay pretty stable from a structural standpoint, and we more focus on managing arrhythmias. So it definitely directs how we're following these patients.
Great. Thank you. Given the exact data and recent papers discussing overcalls of Titin mutations, is it possible that the 5% that had digenic heterozygosity could be an overcall or miscall of one of the genes, and digenic rate is not that high?
Yes, it's always an evolving discussion about the actual pathogenicity of these mutations, which is why I really caution any providers interpreting these variants to involve your genetic counselor in ongoing studying these variants and their pathogenicity overall. We're continuing to learn more and more about Titin and the impact of that, but I think we also have to take the exact data with a little bit of a grain of salt, because we know that all of these diseases have reduced penetrance. So presence of a mutation inexact at an extremely low frequency is not really leading me to ruling that out as a possible pathogenic mutation. I know that half of my patients with pathogenic truncating, PKP2 mutations that I can see tracking in a family, and I know I have 16 families with that same mutation showing disease, I know I'm going to look at half of those pedigrees and see a negative family history. So we know that, there's lots of people running around with these mutations who have no evidence of disease, but that doesn't necessarily mean no evidence of risk.
Thank you. How common is sudden cardiac death the first manifestation of ARVC?
It's rare, but it certainly occurs. I mean, if you look at our initial experience where we had a quarter of the patients presented with sudden cardiac death, in about 2/3 of those individuals, it was the first manifestation of ARVD, and in 1/3 they had prior symptoms, with a fair number of them having syncope between 2 weeks and a year prior to sudden death. And obviously that's the most terrible situation, where someone has syncope, it's not appropriately worked up, they miss the diagnosis, the patient dies suddenly. So that continues to happen more frequently than it should, just because of lack of awareness of ARVD. So I think it occurs, and when it occurs, these tend to be young people, mainly young men, that get this sort of sudden death as an initial presentation. And this just speaks to this really importance of family screening and cascade screening. I mean, it's a tragedy when we've had families where there's been 2-3 family members die, and by doing genetic testing, by identifying the mutation, by screening the family members, very frequently family members are screened, have evidence of disease. We can intervene with exercise changes, getting them off the sports teams, and save their life. So this is really serious stuff, and I know from a clinical perspective, genetic testing has really dramatically changed how we evaluate and manage these patients.
Thank you. In a child identified through family screening, at what age do you restrict activity, and to what extent? For example, school gym class.
So it depends on what they're doing in gym class. Generally, gym class is a pretty small amount of time per day, and they may not be exercising vigorously that whole time. But I would encourage, everyone to talk to their physician about that in their specific family. We generally start offering genetic testing to identify those children at risk to parents, around school age when they're making decisions about sports. And so we really try to start it from the beginning that, these kids aren't in soccer up until age 16 and then have to drop out. It's, we start them in lower level activities and getting involved in piano and theater and other things so that this isn't something that's taken away from them. They've just grown up realizing that this is not the best thing for them given their genetic background.
Thank you. How do you manage family members of a sudden death proband with pathology or autopsy diagnosis, but not a genetic diagnosis?
So we really look hard at that autopsy diagnosis and try to make sure that that autopsy diagnosis of ARVC is correct. Dr. Calkins can probably comment on some of the work that we've done looking at autopsies done here in the U.S. So we try to be very exact at looking at that autopsy and making sure it's ARVC. But if we're pretty confident in that diagnosis, then we follow family members of that individual, same as we would follow family members of a mutation-negative proband who's alive. So, they all need screening. We don't have anything to rule people in or rule people out.
Thanks. If a single mutation has been identified in a family, is it still advisable to get baseline echocardiogram in family members who test negative for that familial mutation, considering that a second mutation could have been missed in the proband?
I would say a baseline echocardiogram is not recommended because echocardiogram is pretty useless in the workup of ARVC. However, a baseline electrocardiogram, yes, would be important. Just a baseline to make sure there isn't anything else. And we are pretty conservative. We don't routinely follow negative family members. However, we do always hedge and let them know, hey, look out for symptoms. If something else, if you're symptomatic, if something comes up, we're always reserve the right to, reevaluate you and revisit what's going on. But we don't routinely follow family members who are negative long-term.
Okay, thank you. Can ARVD patients have VT or VF with normal EKGs?
Yes, we've actually published a paper on sort of EKG negative ARVD. Very, very rare, but certainly has occurred. And we published a paper about 4 or 5 years ago in the series, maybe 5 patients. So it's rare, but it certainly can occur. But in general, if you're screening someone for the ARVD, with each negative test, it becomes less likely. So if you do an EKG, it's normal. Well, that makes it unlikely. You get a Holter that's negative, then it's even more unlikely. Then you get an MRI that's negative, then it's completely unlikely. That kind of thing.
Thank you.
And usually we see electrical manifestations before structural manifestations. So if we're screening, whether it's family members or whatever else that have a mutation, the first things that we tend to see are the EKG changes in the PVCs before we see detectable MRI abnormalities.
Great. Since there is health value in exercise, how much exercise is allowed in gene-positive individuals?
Well, our conclusion of our study, as you remember those slides, was that the AHA recommended amount of exercise to stay healthy is remarkably little. It's like 20 minutes of moderate exercise 4 times a week. So it appears that if you exercise less than that, either at or under that level, that seems to be safe. But in general, we say if you have ARVD, if you're at risk for ARVD, certainly no competitive athletics, no endurance athletics, and you really should be doing light to moderate exercise on an infrequent basis, meaning you can walk, you can play golf, you can go for a stroll, but you should be canceling your membership to the health club.
Thank you. Are there any drugs that ARVC patients should avoid, like QT prolonging drugs?
I would say no. There's no, certainly sotalol is a common antiarrhythmic drug that we see, and we virtually never see evidence of proarrhythmia. So I'd say there's no. I mean, the question always becomes with stimulants. We know that high-dose isoproterenol can really light up patients with ARVD. So catecholamines in general are not good, and that's one of the reasons that we put every patient on beta blockers with ARVD. And I think that's really important. So I think, but do we tell patients they can't drink coffee or they can't have a glass of wine or whatever? No, I think there's not many other restrictions, but high level, massive levels of alcohol are obviously never any good for anybody. Cocaine, things like that are obviously not recommended. Brittney, any thoughts?
No cocaine.
No cocaine.
Great. We all learned something. We've reached the end of our hour, and I'd like to start by thanking our audience for their participation and submitting many questions. We were not able to get to all of them, but we'll make an effort to circle back to our presenters and do our best to get you answers. On behalf of the SADS Foundation, Invitae, as well as our audience, Dr. Calkins and Brittney, I'd really like to thank you for taking the time out of your schedules to share your knowledge and providing us with such an enlightening and interesting presentation. So thank you very much.
Well, thank you, and it was wonderful. I appreciate everyone taking the time to learn about a very important condition.
Thank you.
All right, goodbye.